Hello everyone, myself Dr. Prateek Garg. So today we will discuss about CSF Rhinorrhoea. What do you mean by CSF Rhinorrhoea? See, rhino stand for nose. It stand for nose. And what do you mean by urea? Urea is any sort of discharge. So what do you mean by rhinorrhea? Rhinorrhea is any discharge from the nose. And if CSF Rhinorrhea is a term, that means CSF discharge from the nose. So let's discuss this topic with the help of a question. The question is not true about CSF Rhinorrhea is option number A, occurs due to break in cribriform plate. It seems to be the correct option because in the nose cribriform plate is the thinnest or the weakest area from where the CSF leak is maximally happens. Why? This cribriform plate, it is at the roof of the nasal cavity. Suppose this is the midline and on both the side there is this cribriform plate. It got two lamella. The first one is lateral lamella. This is lateral lamella. And this horizontal part, this is medial lamella. So this is one side cribriform plate. So this lateral lamella, I'm talking about this part, lateral lamella of the cribriform plate is the weakest area in the nose from where any minor trauma may lead to discharge of CSF or CSF leakage. So option number A seems to be correct. Now, CSF Rhinorrhea, option number B, contains glucose. Yes, CSF do have glucose because if we all know the brain needs energy by means of glucose. You need glucose to get the energy for the brain. So CSF do have glucose. Requires immediate surgery. Option number C, we have to think, does every CSF leakage require surgery? No. Most of the time CSF leakage may get subsided or may get corrected spontaneously. Leakage may happen spontaneously and the best treatment is just to wait for few days with the antibiotic support, so that may automatically subside the CSF leakage. So surgery immediately is never required in CSF Rhinorrhea except any major trauma cases or some tumor cases where there is a big hole or big site of leakage. Okay, so option number C seems to be incorrect option and examiner want to ask what is not true. So I think option number seems to be correct answer for this question. Option number D, contains less protein. Yes, CSF do have protein, but in comparison to the blood or we can say plasma, CSF have very less protein. Let's discuss about CSF Rhinorrhea. What are its causes? So leakage maximally, that is 95% cases, CSF Rhinorrhea is because of the trauma. Trauma may be non-iatrogenic or accidental. Accidental again forms the 80% part of the causes. Okay, what are the other causes, other trauma? That is option number B is transverse fracture of temporal bone. We have discussed in the ear lecture how the transverse fracture that runs along the petrous part of the temporal bone and thus may result into the CSF leakage from the nose. Then comes Lee-Ford fracture 2 and 3. What do you mean by Lee-Ford fracture? We know, we have discussed, suppose this is my face and this is my eyes, this is nose and this is mouth. Okay, so Lee-Ford fracture 3. Lee-Ford fracture 3 somewhat run like this. It generally separate my facial skeleton from the skull base. Skull base and face, they both the bone, the fracture line runs in between, so it separate. It makes a demarcation. So that is Lee-Ford fracture 3. Lee-Ford fracture 2, that also run along the eyes and nose, and it involves the maxilla, zygomatic bone, etc. So in Lee-Ford fracture 2 and 3, CSF leakage may happen. Then comes type 3 nasal fracture, and the fourth is target sign. What do you mean by target sign? It is the traumatic CSF leak sign. How we can say that is a target? If we use the intrathecal dye or if we inject some sort of dye into the CSF from the lumbar puncture or anything. So what will happen if there is a trauma and leakage from the CSF? That dye will also come along with that. So because of that, we can get a site from this side the CSF is getting leaked. So that is known as target sign. That is a particular spot CSF getting leaked. So that is target sign. So 95% of the causes of CSF rhinorrhea is traumatic. Then there also occurs spontaneously CSF leak. It may be because of any intracranial tumor, pseudotumor cerebri. What do you mean by pseudotumor cerebri? It is an increased hypertension, increased pressure into the brain without any actual presence of any tumor. So that's why it is known as pseudotumor. There is no tumor in this, but the intracranial pressure got increased. Then there occurs some congenital pathway or empty silla syndrome. In empty silla syndrome, there is a normal pressure leak. That means the pressure is not getting increased, but still we can have this CSF leakage. Okay, so these are some of the spontaneous causes of CSF leakage. Now, how will you diagnose that it is in CSF? Firstly, what you will do, if the patient present to the OPD with the complaint of some watery discharge from the nose, usually CSF leakage occurs from one of the nostril, whereas if the patient is having rhinitis or some allergic rhinorrhea, so patient may have discharge from both the nose. First thing. Second thing, ask the patient to collect that watery discharge from the nose into a sterile test tube or sterile curate or something like that, sterile tube. So then go for the beta-2 transferrin test. Beta-2 transferrin test is a confirmatory test for CSF because never in any allergic or nasal mucinous discharge beta-2 transferrin will not be present. It is only present in CSF. So it is a confirmatory test that this discharge was CSF only. Then how will you detect about the site of the lesion? So we can go for the high resolution CT scan. And how will you localize that this is the area from where CSF is getting leaked? Either we will inject some dye intrathecally. What do you mean by intrathecal? To inject into the lumbar area. We'll do the lumbar puncture and we will inject some dye so that this dye will circulate in that thecal space that is known as the CSF space. So if any leakage in the nose, so we can detect by the help of that dye. Or the other investigation is CT cysternography. If one has to ask what is the investigation of the choice for this CSF leakage, so I will say CT cysternography. In this also we inject some dye and we then go do the CT scan. So we can get exactly where is dye is coming out, so we can get an idea. So this is exact site of the CSF leakage. So this is investigation of choice. And what is the dye which we inject in CT cysternography? Indium 111 DTPA. Okay. Now, how will you differentiate whether it's a nasal secretion or CSF? Firstly, I told you that is a beta transferrin test, which is only present in the CSF. The next one is nasal secretions are thin, and if you use some handkerchief, usually what happens when the nasal secretion get dried up, so the handkerchief will get stiffen. That is because of the mucinous discharge. Okay, and this nasal secretion we can just snip back. We can do like this, so we can stop the nasal secretions coming out. Whether but in CSF leakage you can't snip back. If CSF leakage is there, you can't just again you can't do this. It will come. Okay, and there will be no stiffening of the handkerchief. Okay, and usually as compared to nasal, CSF is little bit thick, and there will be present over the handkerchief. If you see, there will be halo sign will be there. It will look like this on the handkerchief, in which in the center is the blood and periphery it is the CSF. Okay, and there is one more sign in CSF leakage is the reservoir sign. So whenever patient bends his nose downwards, like if he try to touch his chin to the chest, so all the CSF that will directly come, it's like it was stored somewhere and suddenly it is coming out. So that is known as the reservoir sign. It will not happen in nasal or rhinorrhea or allergic rhinitis. Now, what is the most common cause? We have already discussed trauma is the most common cause, and most common site is lateral lamella of the cribriform plate, which is the weakest area in the skull base. And this has been asked multiple times into the exams. Okay. Now, let's have an idea about the composition of CSF or the blood. CSF do have protein, as I have told you, but it is very less. Look at this protein. Suppose in the blood the amount is around milligrams 7000, so in CSF it's only 28. So very less protein, but it do have protein. Another the option was glucose. So in the blood glucose is there, In CSF, glucose is again there, but as comparative to plasma or the blood, it is less. Then CSF do has sodium, potassium, magnesium, calcium, but comparatively it has less calcium, magnesium. In sodium, CSF do have little bit more sodium as compared to blood. Very less difference, but it is there. Okay. pH, if we talk about the pH, we all know the blood pH is 7.4. But in CSF, it is little bit acidic, very mild acidic. As compared to blood, it is 7.3. Okay, so what is the treatment? The ideal treatment for any spontaneous or traumatic CSF leak is just to wait conservatively for 10 to 15 days. That is 1 to 2 weeks initially. It's always better to manage conservatively. What we do, we will ask the patient to maintain his position in a propped up position, that is head up. Okay. And then we will ask the patient to have less motion or like to take rest properly. We will give an antibiotic support to avoid any sort of infection in the meninges. And what is the other medical treatment? We can use mannitol or glycerol. These mannitol or glycerol are the hygroscopic agents which decreases the intracranial pressure, and thus they help in reducing the CSF leakage by reducing the pressure. If this conservative treatment doesn't help, then we go for the surgical repair, where what we do, we just localize the site of CSF leakage by means of CSF cysternography or something else. And nowadays endoscopic surgery is preferred, and what we'll do, we will just localize that site, then denude the area or remove the mucosa, and then put either a fat plug, some sort of fascia, or we can just block or just stop that leakage by putting some fat or some fascia or some other graft into that. Now again, another question. Immediate treatment of CSF rhinorrhea requires. I hope you all can answer now this. Option number A is antibiotics and observation, which seems to be the correct option. Plugging with paraffin gauze. No, if you plug with the paraffin gauze, obviously it will invite the infection. So it is never advised in the CSF leakage. So it is an incorrect option. Surgical endoscopic correction. Yes, this is required, but not immediately. Firstly, we have to try a conservative management. Then we can go for the surgery if conservative management doesn't help. Craniotomy nowadays not very recommended because we can repair it surgically. So I hope